If you've ever had that moment where something feels off with an aging parent and you don't know what to do next, this episode is for you. If you have ever told a parent to call an ambulance because it felt safer than guessing, this episode is for you. And if you are a hospital leader carrying problems that did not start inside your walls, this episode is for you. Hi there, and welcome to Health Law with Ravi, your friendly guide to the world of healthcare law. Here we make healthcare law human, approachable, and a little more exciting than you might expect. We'll break down regulations, policy, and operational decisions that shape the care people actually receive, and uncover insights you can really use. Quick heads up, although I'm a healthcare partner at Bradley, the views expressed here are my own, and not the firm's or any of its clients, and they're not intended as legal advice. But I promise to make this fun, insightful, and practical. Whether you're a healthcare executive, attorney, clinician, or just someone who wants to understand the system better, you're in the right place. This is Health Law with Ravi. Hi there, and welcome to Health Law with Ravi. Today I want to introduce the topic of hospital overcrowding, not as a crisis headline or a staffing problem, but as something deeper and more structural. Hospital overcrowding, it's a system imbalance that has been building quietly for more than a decade across the entire care delivery's life cycle. Emergency departments that never seem to clear, patients boarding for hours, sometimes days, patient boarding meaning patients in the hallways of an emergency room for days, clinicians doing everything they can while stretched thin, families anxious and unsure where to turn next. And this is not isolated. We see it across Florida, Georgia, across the Southeast more broadly, and very clearly in Texas. And here's the grounding truth. Hospital overcrowding is not a hospital failure. It is the system asking hospitals to carry more than they were ever designed to hold. Before I go any further, I want to say something about this episode. This one's a little different. I'm not walking through a specific regulation or a policy change today. Instead, I'm trying to show how small, rational decisions made by families, clinicians, and hospitals add up to the overcrowding that we are all feeling. This episode is about the space in between the rules, the part of the system that no one really owns but everyone feels. So why is this overcrowding not temporary? And why is it a topic I've been talking about and thinking about for really over a decade, well before COVID? Hospitals know how to handle surges. Flu season comes and goes. Tourist season have patterns. Even disasters, while intense, usually have an endpoint. And what feels different now is that the pressure really never lets up. Across much of the Southeast, population growth has not just increased volume, it's increased complexity. Patients are older, sicker, and living with multiple chronic conditions. The emergency department has become the most reliable place to access care, not just for emergencies, but for everything else that's difficult to get quickly. This does not feel temporary because it is not. It's structural. So where does the system break down first? Emergency departments, they're often blamed for overcrowding, but emergency departments are not the cause. They are where everything else shows up. A familiar situation looks like this. A patient is medically ready to leave the hospital. The plan is clear, everyone agrees, but the patient cannot go anywhere. There's no skilled nursing bed available, home health cannot start in time, equipment approval is still pending, or a family caregiver lives out of state and cannot get there for days. So the patient stays. The bed stays full, the emergency department backs up, clinicians keep juggling. From the outside, it looks like inefficiency. From the inside, it's gridlock caused by pieces that do not line up. What are the quiet drivers that no one talks about? Some of the biggest reasons hospitals feel so full are also the least obvious. Prior authorization is a good example. It's often described as a billing problem, but in real life, it's a space problem. When approvals take days instead of hours, patients stay put and hospitals become holding areas. Staffing matters in the same way. Not just doctors and nurses, but case managers, social workers, utilization teams, transport, and environmental services. When those teams are stretched thin, discharge is slow, beds do not open up, and pressure builds everywhere else. Hospitals that treat these roles as essential to capacity, not as back office support, tend to move patients more smoothly, even under strain. And one part of this conversation that rarely gets said out loud. Caregivers are not careless. They're scared. Many adult children are caring for parents from another city or another state, or from even an hour drive or 45 minutes away. They cannot see what's happening. They cannot tell whether something is minor or serious. And when a parent sounds confused, weak, or unsteady, the safest option sometimes feels like calling an ambulance. Not because the emergency department is always the right place, but because it's the only place where someone will definitely look. Urgent care may be closed. Primary care may not have same-day access. Virtual care may feel like too much of a gamble. That decision makes sense in a system that does not give caregivers a clear path. And hospitals, they feel the downstream impact of these choices, but they did not create the conditions that make these choices reasonable. And it's really just a joy and a privilege to watch many of our systems in the Southeast be innovatively thinking through some of these problems. Some have centralized teams that manage discharges and transitions, so hospitals are not all trying to solve the same post-acute and transportation problems on their own. Others have expanded care models that allow certain patients to be treated safely at home or observed without a full hospital stay. And that frees up beds and gives families reassurance that someone is still paying attention. Some emergency departments bring social workers and care managers in early, especially for older patients, to help decide who truly needs admission and who could be supported another way. And more systems are involving legal and compliance teams earlier, while care programs are being designed, so new approaches actually work in the real hospital settings instead of getting stuck later. But these steps don't fix everything. They reduce friction. Another pattern I see is that some health systems are starting to understand what caregivers have known for a long time. The hardest part of caregiving is not the work, it's the uncertainty. You're not choosing between bad and good options, you're choosing between options that all feel risky. Some systems are responding by treating caregiver guidance as part of how care works and not something extra. In integrated systems, this is easier. When primary care, urgent care, virtual care, and the hospital are all connected, caregivers are not forced to guess where to go next, or where the patient has been. They are given a path. Families are told clearly what nurse advice lines are for and when to use them. That message is repeated during routine visits, included in visit summaries, and sent to family members through patient portals so that it's there before something goes wrong. Virtual care is explained in plain terms, what it can handle, what it cannot, no judgment, just clarity. Transitional care teams introduce themselves early. Families know who will call, when that call will happen, who to contact if something feels off once the patient is home. Some hospitals are very intentional about how they explain hospital at home and observation programs. They are described as real, monitored care, not shortcuts, not second-best options. What makes the difference here is consistency. The same guidance shows up in the clinic, in the hospital, and after discharge. Over time, caregivers stop feeling like they're guessing in the dark. Education does not mean families need less care. It means they're less likely to seek care out of fear alone, and that matters. Most importantly, many caregivers are managing parents from far away while balancing work, children, and their own health. Systems that are adapting well are designing for distance, virtual caregiver orientation, named care navigators, proactive communication. And the goal is not to replace family presence, it's to reduce panic when caregivers cannot be there. You can see some of this recognition starting to show up at the policy level also. CMS has been testing ways to safely move appropriate care out of traditional hospital beds and has been paying closer attention to what happens after patients leave the hospital. That tells you something important. Hospitals have been managing these pressures for years, and policy is only now beginning to catch up with the reality on the ground. I talk more about that in a separate episode on the team model, because what happens after discharge often determines whether patients come right back. Why does this matter to me? I care not just as a healthcare lawyer, but as someone who's watched families, including my own, struggle to navigate care for aging parents. I understand why it can feel safer to have a parent in the hospital, even when the system is strained. But I also understand why hospitals feel overwhelmed when they become the default solution for gaps that exist elsewhere. And both of these things can be true at the same time. I want to come back to something I said at the beginning. This episode is not about one rule or one policy, it's about the space between them. Hospital overcrowding, it's what happens when a lot of reasonable decisions, made under pressure, stack up inside a system that was never designed to support all of them at the same time. Caregivers are trying to keep their parents safe. Clinicians are doing extraordinary work inside real constraints. And hospitals are holding together a system that doesn't always hold itself together. If we want hospitals to be less crowded, we have to stop teaching families during emergencies and start giving them a map before they are afraid. And until then, hospitals will stay full. Not because they're failing, but because they are doing exactly what the system asks of them. Thanks so much for listening to Health Law with Tara Ravi. I hope you'll find new ideas, helpful insights, or even a little inspiration along the way. If you like this episode, hit subscribe so you never miss a conversation, and share it with colleagues, friends, or anyone passionate about their healthcare. Everything we've talked about, episodes, insights, and conversations, is waiting for you at tararavi.com. Don't forget to check out the Resources tab on the website, where you can access laws, guidance, or materials referenced in today's episode. See you next time when we continue exploring health law with some heart.